Hello, this is Dr. Kurt Tribble from the University of Mississippi. I'm going to narrate this talk on cardiac tumors. Josh Cockrell, one of our cardiology fellows, and I put this together over time and thought it would be appropriate for the TSDA curriculum. Primary cardiac tumors are quite rare and are well under 1% in autopsy series. However, secondary cardiac involvement by extracardiac tumors is much more common. 75% of the cardiac tumors are characterized as benign neoplasms, and cardiac myxomas account for about half of those. The remaining 25% of cardiac tumors are considered to be malignant, and the majority of these are sarcomas. Cardiac tumors can be divided into three groups. The first is pediatric tumors, which are mostly in the category of being hamartomas. The second is benign tumors, both non-neoplastic masses and benign neoplasms. And the third group is malignancies. As mentioned, these include the primary cardiac sarcomas, lymphoma, and especially metastatic tumors. In adults, primary cardiac tumors typically arise from the endocardium, followed by myocardium, and infrequently arise from the pericardium. The origin of metastatic lesions, or the locations of these metastatic lesions, are actually the reverse, with the pericardium being most common and endocardium being least common. The clinical presentation depends on the size, location, mobility, friability, and histologic type. There are four general categories of symptoms one may see in a person with a cardiac tumor, and they include systemic manifestations, embolic manifestations, cardiac manifestations, and metastatic effects. Systemic manifestations include constitutional symptoms like fevers, chills, malaise, and weight loss. Myalgia, arthralgia, muscle weakness, and Raynaud's syndrome are also common. Myxomas frequently cause systemic symptoms, and these symptoms are thought to be mediated by interleukin-6. Some of the lab abnormalities you may see when constitutional symptoms are present are leukocytosis, either polycythemia or anemia, thrombocytosis or thrombocytopenia, an elevated SED rate or C-reactive protein, and hypergammaglobulinemia. Everyone's familiar with the concept of embolic phenomena occurring from cardiac tumors. These could be systemic or pulmonic, depending on which side of the heart they have arisen in. There can be embolization of tumor particles or clot that is formed on the tumor itself, which would be thromboembolism. The propensity to cause embolic events includes whether the tumors are intramural or intracavitary, the type of tumor, and the friability of the tumor surfaces. When considering embolic phenomena, we turn first to the benign tumors. Myxomas are particularly prone to embolize, especially those that have a villous surface on them. Also, papillary fibroelastomas are prone to embolize, and hemangiomas and lymphangiomas can embolize as well. Malignant tumors have a relatively high likelihood of embolism when they have friable and necrotic luminal surfaces. The brain is the most common site of embolization, but of course emboli can go to any organ or tissue. Bilateral hemispheric involvement or multiple vascular regions should always raise the suspicion of an embolic phenomenon. Typically, these events can be manifested as a TIA, but they can have ischemic strokes, of course, and some of these are associated with hemorrhage. The cardiac manifestations of tumors include direct mechanical interference with myocardium or valves. They can occur on the left or right side of the heart. They can occur in the pericardium or the muscle of the heart, or in the cavities of the heart, and these manifestations are partly, of course, dependent on the size. There can be interruption of blood flow, conduction system abnormalities, and pericardial effusions. So let's look at left atrial tumors. Myxomas are the most common. And these can cause symptoms by obstruction or mitral regurgitation. They can simulate mitral valve disease, that is mitral stenosis or mitral regurgitation. And they can cause secondary pulmonary hypertension. It is said that the astute clinician can hear a tumor plop sometimes when the myxoma is moving around, which is an early diastolic low-pitched sound. The symptoms of a myxoma may be positional depending on where it moves with different positions of the body, and myxomas are frequently associated with thromboembolic phenomena. The most common right atrial tumor is also a myxoma. However, sarcomas, especially angiosarcomas, can arise in the right atrium as well. These tumors can cause obstructions similar to tricuspid stenosis with signs of right heart failure, and there can be embolic events to the pulmonary vasculature. If the right atrial pressure rises, there can evolve a right to left shunt via patent foramen ovale, causing hypoxemia and paradoxical embolization. Shifting now to right ventricular tumors, these tumors may interfere with right ventricular filling or outflow. The patient may present with right heart failure symptoms, and the patient may be misdiagnosed as someone having pulmonic stenosis, restrictive cardiomyopathy, or tricuspid regurgitation. The pictures here on this slide reveal a mass in the right ventricle and multiple nodules in the pulmonary parenchyma caused by embolization from a right ventricular tumor. Left ventricular tumors may be intramural or intracavitary. Those that are intramural may cause arrhythmias, conduction defects, and left ventricular systolic dysfunction. The intracavitary tumors can cause systemic embolization, outflow tract obstruction, syncope, and left ventricular failure. Now let's look at some of our imaging modalities, including echo, MRI, and cardiac CT. Echocardiography is the most widely used modality to evaluate the heart for the presence of tumors. A schematic of the heart is shown on this diagram, and the corresponding echo view is right above it with labels showing which part is where. Echo is attractive because of its non-invasive nature, its ready availability, its lack of exposure to radiation and contrast, as well as good spatial and temporal resolution. Is highly sensitive, with the transesophageal echo being the most sensitive. The echo allows the assessment of the presence and degree of obstruction to blood flow and valvular regurgitation. It allows the visualization of the myocardium in the chambers, and it will, through defining the features and locations, give a clue as to the tumor type. Cardiac CT and MRI are superior modalities for characterizing the tumor type, assessing tumor involvement or infiltration, and this is especially true on MRI, visualizing extracardiac structures. This is especially true for CT, and it is felt that MRI is typically better overall, with T1 and T2 images providing clues to chemical microenvironments that may characterize tumor makeup. MR is also helpful in distinguishing thrombus from tumor. Here are some examples of cardiac masses that have arisen in the atria. In A, we see a gross photograph of a smooth surface myxoma that has been sectioned down the middle. B, we see the axial chest CT, which demonstrates a mass within the left atrium which appears to be attached on this study to the interatrial septum. C shows a gross specimen of atrial leiomyosarcoma, demonstrating multilobular and irregular features. D is an axial chest CT, which demonstrates a large soft tissue mass which fills the left atrium. E is a gross photograph of a resected atrial thrombus, demonstrating surface thrombus, which is brown in the fixed state, organized white thrombus underneath, and a portion of the excised atrial septum at the bottom. F shows an axial CT cut, which demonstrates a soft tissue mass contiguous with the posterior wall of the right atrium and the interatrial septum. The imaging impression was atrial myxoma, but when resected, the histology was of organized thrombus. There was no history of a coagulation disorder in this patient. A useful way of categorizing tumors is by whether they are benign, malignant, or if they are a secondary malignancy. The benign tumors include myxomas, papillary fibroelastomas, rhabdomyoma, fibroma, teratoma, lipoma, lipomatous septal hypertrophy, and Purkinje cell hamartoma. The myxomas are, of course, the most common type of primary cardiac tumor. They are typically diagnosed as an incidental finding on an imaging study. They do account for a third to even a half of all primary cardiac tumors, with the vast majority of those being in the left atrium. 5 to 10% of these have a familial pattern or association called the Carney complex. The classic triad of findings and symptoms for myxomas are obstructive cardiac findings, embolic events, and constitutional or systemic signs. It is said that embolic phenomena occur in 30 to 40%, and 20 to 30% have constitutional signs. On echo, these lesions are mobile, pedunculated masses attached to the endocardial surface, and most commonly arising from the fossa ovalis. About half will have a relatively smooth surface, and the others will have a rough or villous surface. It is felt that all of these need to be resected due to the risk of thromboembolic events. The Carney complex is an autosomal dominant syndrome with cardiac and non-cardiac myxomas. There is abnormal skin pigmentation as seen in the picture on this slide, which is supposedly characterized by a blue nevi. There's endocrine hyperactivity such as Cushing's syndrome, as well as testicular Sertoli cell tumors and pituitary tumors. This complex usually presents in the third decade of life, and the tumors have a high recurrence rate even after resection, with the recurrence rates as high as 30%. Screening echocardiography is recommended for first-degree relatives. Papillary fibroelastomas usually occur on the valves, and these valves are usually on the left side of the heart. They have a sea anemone appearance. Symptoms when they are present typically occur from embolization from the fronds, with TIAs and strokes being the most common. The treatment is resection of these lesions in a patient, especially with a history of embolization, or in asymptomatic patients with highly mobile tumors. It has been shown that mobility is an independent predictor of death or non-fatal embolization when these tumors are present. Some say that asymptomatic patients with small, non-mobile tumors can be observed. This slide has an echo with a papillary fibroelastoma on the aortic valve. You can see it best in the view to the right, where the arrow is pointing at the nodule, and if you look back to the left, you can see in the closed valve where that nodule actually sits on the cusp of the edge of one of the cusps. Here are two photographs comparing a papillary fibroelastoma with a real sea anemone. You can certainly see the similarity there. A 9-year-old woman was hospitalized for ischemic cardiomyopathy and anemia. On day 19 of her hospitalization, she suddenly collapsed and had an unsuccessful resuscitation. At autopsy, a papillary fibroelastoma was found, occluding the ostium of the right coronary artery, generating this photograph, which is certainly a dramatic example of what this tumor could do. Rhabdomyomas are the most common cardiac tumors in children. 80% of these turn up in children under a year of age. 80 to 90% are associated with tuberous sclerosis. They usually involve the ventricular walls, and they can occur on the AV valves. Most regress spontaneously, and resection is required only if they are symptomatic. An echo is shown on this slide that shows a rhabdomyoma. Fibromas are rare, though they are the second most common cardiac tumor in children. 90% of them do present in children, but they can present at any age. They usually arise from the LV free wall, the ventricular septum, or apex. By echo, a fibroma appears as a well-circumscribed, calcified mass. Heart failure is the most common presentation, and it is usually caused by some obstruction or valvular dysfunction. But there can be malignant arrhythmias also associated with these tumors. The treatment is to have this lesion resected if it's symptomatic. They will not regress. In these echoes and CT scans are pictures of a left ventricular fibroma in a 55-year-old man. Panel A, which is the echo, shows a 4-chamber view revealing a large homogeneous mass arising from the lateral wall of the left ventricle. The unenhanced CT scan in panel B shows coarse calcifications in the region of the lateral wall of the left ventricle where the arrow is pointing. The contrast CT shown in C reveals the calcifications are seen within the large attenuated, low attenuated mass, which diffusely replaces the lateral wall, again indicated by the black arrow. And the final pane is a T1 weighted MR image showing the homogeneous low signal intensity mass in the lateral wall of the left ventricle. Teratomas usually arise from the pericardium. They are most common in infants and young children, and 80% are benign. As you'll recall, components of teratomas will include all 3 germ layers and may have hair, skin, muscle, even teeth. They may cause hemodynamic compromise due to tamponade or direct pressure. The treatment for these tumors is to excise them when possible. Lipomas and fibrolipomas are well encapsulated, benign tumors of fatty cells. They can occur in multiple locations, but most occur in the subendocardium, followed by the subepicardium, the myocardium itself, and valves. They are slow going, but may reach large size, and there have been reports of lipomas that were over 4 kilograms. Symptomatic compression can occur, as can pericardial effusions or conduction abnormalities. These should be resected if the patient is symptomatic. The figures reproduced here show some lipomas of the heart. Lipomatous septal hypertrophy is not a true tumor, but we include it in this review because it can be mistaken for a tumor. In fact, it's an exaggerated growth of normal fat in the interatrial septum. It's more common in the elderly and in the obese, and it's more common in men. It generally does not require treatment, though it is occasionally associated with obstruction of the SVC and with supraventricular tachycardias. The appearance on echo is of a dense globular thickening in the interatrial septum with a sparing of the fossa ovalis. There can be a dumbbell appearance as shown in the echo reproduced on this slide. To humor one of our faculty members, Dr. Fike, we threw in this article from the Journal of American College of Cardiology when he was a fellow at the Mayo Clinic. This article described lipomatous hypertrophy of the atrial septum. Purkinje tumor hamartomas occur on the LV, endocardial, and epicardial surfaces. They are not detectable by imaging. They are known to be present in young children with incessant ventricular tachycardia. The treatment for these tumors is an EP study to localize and facilitate surgical resection. Tumors that can be either benign or malignant include paragangliomas and mesotheliomas. Paragangliomas are hormonally active, though sometimes inactive, tumors, the majority of which occur in the left atrium. They can produce norepinephrine and dopamine and cause such constitutional symptoms as headaches, sweating, hypertension, and tachycardia. The hormonally inactive tumors tend to involve the pericardium. They are highly vascular and parasitize the cardiac blood supply. Some of their effects can be treated with adrenergic blockade when preparing for resection. Mesotheliomas are rare, and they are usually malignant and usually involve the pericardium. There are benign variants of this tumor. The pericardial mesothelioma is not as clearly associated with asbestos exposure as are the pleural or lung-based mesotheliomas. Pericardial-based mesotheliomas can become symptomatic with tamponade or constriction playing a role in creating the symptoms. Rarely, a benign mesothelioma may involve the AV node causing AV block. The treatment, when feasible, is resection, though there is a very poor prognosis for the malignant variant of mesothelioma. The most common malignant tumors of the heart are sarcomas, and they include angiosarcomas, rhabdomyosarcomas, fibrosarcomas, leiomyosarcomas, osteosarcomas, malignant fibrous histiocytomas, and some others. All of them have very bad prognoses. The treatment is resection if possible, but it's not possible in most cases and most recur. Angiosarcoma is the most common primary malignant cardiac tumor. 80% of these arise from the right atrium near the AV groove. They present with chest pain and right-sided heart failure, and frequently the patients will present with hemopericardium, tamponade physiology, or perhaps rapid heart rates. Cardiac MR typically shows a sun ray appearance from vascular lakes. They may also present with metastases to the lungs and liver. Lymphomas involved in the heart are mostly diffuse large cell tumors, lymphomas of the B cells. These are most common in immunocompromised patients, including HIV positive patients, transplant patients, etc. However, only 5% of all lymphomas in this population are primary cardiac lymphomas. MR is the best imaging modality, and the treatment is a trial of reduced immunosuppression in the transplant patient and a trial of chemotherapy, which is anthracycline based with or without other supplemental chemotherapeutic agents. Secondary cardiac tumors are 20 to 40 times more common than primary tumors. In one autopsy series of 1,900 patients, 8% of the patients who died of cancer had evidence of metastatic involvement of the heart. Common cancers associated with cardiac involvement include malignant melanoma, which is the most common, lung, breast, soft tissue sarcomas, renal, esophageal, hepatocellular, and thyroid. These are some references that we used in putting together this talk, and thought you might like to have access to these.